tonight's program is an MS Views Now program. It is primarily, we're going to be speaking about treatment options, emerging therapies, and a few other things. But first, I want you all to see our supporters for this program. We have Sanofi, SANDOZ, Bristol Myers Squibb, Genentech, and Biogen. And virtually, we want to thank them. So I am thanking them. All right, and as we go forward, we're talking about tonight's program. We have Dr. Annette Okai, as I mentioned, and she is an MS neurologist from the Dallas region. I don't remember the exact town, but it's in the Dallas, Texas area. She'll tell you about that after. We are talking about, or she will be speaking and presenting about, discussing the and understanding treatment options for MS today. All right, not what we did 20 years ago. All right, and she'll be speaking about new medications, emerging therapies, biosimilars, and a few other things. So let's welcome Dr. Annette Okai.
Thank you so much, Stuart, for that introduction. And I do remember our first program in the age of COVID and trying to navigate the world that we have been thrust in the lockdown. So I applaud you for continuing and coming this far in the past 2 years and keeping the information flowing and educating patients. I am happy to be here today. I'm going to talk a little bit about the updates that we have in MS. So moving forward, the agenda for tonight, I'm going to give a brief overview of MS. And no MS talk is ever complete without talking about the disease itself. But also, we don't want to miss those people who are new to new to MS, just giving them some basic information. Then I'm going to talk about understanding what the treatment options are, shared decision making, and then look at the future landscape. Obviously, this is designed to be condensed into an hour program. So this isn't all there is to it, but I will try to make it as relevant as possible and get the salient points out so that you may leave here tonight with some form of education. So what exactly is MS? MS is an autoimmune disorder. What does that mean? It means that one part of your body is attacking another part. So it's not anything that comes from the outside. It's internal. It's self-attacking self. And when that happens, it causes demyelination, which is loss of myelin or damage of myelin of the central nervous system. I'm going to go into that a little bit more. It affects more women than men. And MS is characterized by relapses where people have attacks or exacerbations. Those are other words for it. And then they have periods of remission and then relapses again. The symptoms may vary. It may be anything from motor symptoms where there's weakness of the arms, the legs, or different parts of the body, the face. It may affect cognition. It may affect vision. It may affect bowel and bladder, or you may have sensory symptoms. These are just a few of the common symptoms that we see with MS. There are lots of other symptoms that may occur. Everyone is different. Everyone may not experience the same type of symptoms, and the treatment plan may be different for them, but there are some commonality between all of them. So I mentioned the central nervous system on the last slide. What does the central nervous system consist of? It consists of the brain, the optic nerve, which is of the eye, and the spinal cord. Those three components make up the central nervous system. That's where you have all your nerves. And your nerves are designed to operate in a very efficient fashion where electrical impulses are sent at an efficient speed that you do not even recognize it. And what helps that to conduct the message? The nerves are wrapped in myelin, hence the term you heard before, demyelination. Well, the immune cells attack the nerve and damage the myelin. Depending on where the damage is, That's where you see symptoms that can occur. If the damage is affecting the optic nerve, people will have symptom of optic neuritis, where you have blurred vision or double vision or wavy vision or some type of vision change. If it's affecting the spinal cord, normally you have your arms or your legs or bladder and bowel being affected, and the brain can affect different parts of the body. So it's important for this slide that you know the central nervous system has 3 parts. The myelin is what is being damaged the most, and where the damage is the type of symptoms you have. On the next slide, we see that I just broke it down into the types of cells of the immune system. Now, I also put this here for a specific purpose because later on I'm going to be talking about shared decision making, and you're going to see this slide again. So the cells of the immune system are there to protect someone from any outside attack. So in terms of bacteria entering your body, or viruses entering your body, or parasites or fungus, any kind of outside invader, the immune system is there to help protect you from that. But what happens in MS? Those cells that are supposed to be protecting the patient now becomes confused and they turn against the person and look at the myelin as foreign. Why does this occur? We do not have the exact answer at this time, but the players that we have identified include B cells, T cells, and then you have those that generate what we call inflammatory cytokines, and they release that into the central nervous system, and those inflammatory immune cells release the cytokine, and it goes and causes the damage to the myelin, causing the symptom. So really, MS is really a disease of the immune system that affects the nervous system. All right, so now that we know the players of the immune system and how it affects the nervous system, we can move forward to the next part and put all of that together. When the MRI is very important for healthcare providers that treat MS. It helps us make the diagnosis of MS. It helps us monitor our treatment response and also identify certain things that may be affecting patients. So what we see on the MRI, and we call the abnormalities that we see are called lesions. And lesions are really a representation of what the damage that the immune system has done. So when that myelin is damaged, it affects the white matter of the central nervous system, and you see white spots or lesions or plaques. Those are all interchangeable words that your healthcare provider may use, and you see them on the MRI. I have 3 MRIs out here. I have the brain showing those white spots, and I also have the spinal cord showing a lesion on there as well. But this is just a reflection of what the immune system has done, and that gives the provider an idea on how to proceed and make treatment decisions or stratify risk from these lesions that we see in the central nervous system. MS comes twofold, as we now recognize. In the early stages of MS, I talked about the inflammation that may occur from those inflammatory cells. They release the cytokines, and then they go and damage the myelin around the nerve, and sometimes they damage the nerve itself. But what happens later on in the disease course is not, there's a shift from inflammation to degeneration. Now, we don't know exactly when that shift occurs, and we really can't say the true nature, but what we can postulate is that with repeated inflammation and repeated damage to the myelin, you have the nerve that is now exposed. So when the nerve is exposed and it doesn't have any protection around it, then it's also now susceptible to damage. And that damage can lead to degeneration. So think about it as the nerve losing its support. And when you do not have support, then you start to degenerate. And then you enter a phase where the axon itself is being lost, and that happens to produce symptoms where you are not having inflammation. So some of my patients, they may experience progression in their clinical symptoms, and they come and say, I'm having more gait abnormality, or I'm having more cognitive issues, but you're telling me that my MRI is stable. Well, I mentioned that the MRI shows the damage that is done by the immune cells. Well, when degeneration is occurring, the MRI is not a sensitive tool for the healthcare provider to measure degeneration. But we know that is occurring because our patients continue to progress. So early on, you have a lot of inflammation, and that causes demyelination. Later in the disease course, you have loss of axon because the axon has now lost the support of the myelin, and that causes degeneration. Okay, now that you've had the background of what MS is, how it occurs, and what we look for on MRI. Now, and I talk about the players in the immune system, including all the T cell, B cell, inflammatory cytokines, the pro-inflammatory cells that may occur. Let's talk about our MS treatment. MS has been around for a very long time, in the 1800s actually, but we only got therapies, and we call them disease-modifying therapies because they're the ones that actually change the course of the disease. What do I mean by change the course of the disease? Reduce relapses, reduce attacks, reduce MRI activity, thereby reducing disability progression. Now, there are some people on this call who has had MS for a very long time, and there are others who are new to MS. But the first approved FDA therapy for MS was in 1993, after 100 plus years of knowing about this disease. 1993, that speaks to how complex the disease is. I made it sound so simple when I said there's inflammation and there's degeneration, but the complexity is far more than that. And so it took a long time, but our first approved therapy was in 1993. It started with the interferons. And what I did with this slide was I tried to color code it. Green are injectable therapies, light blue are oral therapies, and then purple are infusible therapies. So from 1993 to 2004, we had the interferons and Copaxone. It was the ABCR, or CARB as we call it, and they were only injectable therapies. And then later on, in 2004, we had natalizumab come onto the scene, and mitoxantrone was also on the scene as well. Well, as the years progress, you see, as from 1993 to 2004, that's 10 years. It was only self-injectable. Then we had two medications introduced the next 10 years. But after that, we have had an explosion of new medications, and that's just because we now understand the disease a little better. But of course, the more answers you find, the more questions that come about. But this is the golden age for MS patients. We have so many options for them that we have changed the course of the disease. And disability, the outcome is disability is not the eventual outcome anymore. So from 2010 onward, we see an introduction of different types of medication with different mechanism of action. So interferons, 1993 to 2000, we only had two mechanisms of action. Then 2004 rolls around, we have another one. And then 2010, we have a different mechanism of action, even though I said, oh, here's an oral, and here's an infusion, and here's an injection. Most of these medications have different mechanism of action. As we advance later on into recent years, now we have therapies that are generic, so they are copies of certain medications, and we have biosimilars. And I'm going to go into that a little bit later. But I mean, this slide, when I was putting this slide together, I was looking for space to put all the medications that we have on the market. And I thought, this is a good thing. We're really getting crowded. But this crowdedness that we're seeing is a good thing for patients, because then we have more options and we have different mechanism of action that we can try to tailor to the patient's disease and the patient's need. And so when we move forward, we should keep this slide in mind for the next couple of slides. So this is just a background. As I said, the first drug was approved. And then in 2004, we had natalizumab, which was a different mechanism of action. It was a monoclonal antibody, and changed the course of the disease and how it acted. And then I put oral options, but those oral options all had different mechanism of action. And then since 2014, we had newer generation of monoclonal antibodies coming onto the scene. All right. So when we look at the next slide, I put this slide up. It's a busy slide, but I wanted to highlight the busyness because, once again, MS is a complicated disease, and trying to find the target for treatment is very complicated. You put one key in, it opens it, but there are lots of other doors, and you need several other keys to get into the central nervous system. Remember, we talk about that. Get into the central nervous system to have an effect. So all the therapies that we have on the last two slides, I talk about the different mechanism of action. This slide just goes to show that the targets of our MS therapy are in different parts. It can be outside of the central nervous system, and it can be inside of the central nervous system. We haven't gotten inside of the central nervous system as effectively as we would like, but that's in upcoming and future therapies. So it's a busy slide. But the aim is designed to show you that it's very complicated. So for patients who are on the call, when you go and talk to your healthcare provider, it's not as simple as ABC or one shot here or one pill here. There are lots of other things that go into it, and we need to keep that in mind. And so when for patients, we talk about keeping that in mind, and I talk about the complexity of MS. I talk about the complexity of the medications that we have. But you have to remember that you have certain goals after you have been diagnosed with MS. And when you see the provider looking at you as a patient, look at your disease and have certain goals for your disease, but everyone is working towards a common goal, which is keeping MS under control. So when the decision is being made in terms of what medication to prescribe, in terms of what's going to control the disease, the provider is there to give certain information, and the patient is there to give certain information. MS for a long time was known as the disease where the patient has a lot of input. And why is that? If you went to a cardiologist and you had a heart attack, there's not a discussion about, oh, look, this medication and it's going to work this way and it's going to discuss this way. The cardiologist is going to say, you've had a heart attack, and this is the medication we give for people who've had a heart attack. MS, the patient and the provider actually sit down and have a conversation about the best decision. And there were times that patients went and said, I want to start this medication. But this process where the provider and the patient sit and make a decision about the correct treatment option for them is called a shared decision-making process. I'm saying shared decision-making. So it's not for the provider to go and give a monologue about what drug that the patient should take because it's prescribed. And it's not for the patient to go and share with the doctor the medication they want to be on because they read. No, shared decision-making is taking the strength of the provider and the patient, putting them together to come to a goal. So what does the provider bring to the table for the shared decision-making process? The provider brings evidence of the medication, how it works, and evidence of the disease and how it's affecting the patient. The provider talk about the guidelines, what we see on MRI, what we see on clinical trial, on the clinical exam, and how do we approach and reconcile that in terms of medication. The provider discussed the goals of treatment, and then based on the experience, and I say the experience of the provider because we are working with these medications all day and every day, we have a practical experience, and we can apply that when we make decisions. I sometimes tell my patients, I say, anyone can read a manual, but can you really apply it? Do you have experience? So a car has a manual, and if you look at that manual, it can basically tell you how to build an engine. But by reading the manual, does that make you an engineer? No, it doesn't. So patients, I encourage them to be knowledgeable about the disease and to read, but also look to the provider for that experience in interpreting the data and providing a context of what the patient is reading to them. From the patient perspective, what providers would like to know, what is important for patients to share is, okay, this is the lifestyle I have. Is this medication gonna fit this lifestyle, fit my lifestyle, doctor, that you're prescribing to me? And I would like to know if I'm talking about a medication and a patient feels that it's not gonna fit in their lifestyle. I like to know that because compliance is key. And if it's not fitting into that patient's lifestyle, that affects compliance, that affects adherence, and then we are not meeting the goals of treatment. What does the patient value in their disease, in the MS journey? So something that will be important to share with the physician, so that the recommendation for treatment may fit into them. And patient preference is huge, and something that should be discussed. Back in the 90s, 93 to 2000s, when there was only self-injectable medication, a patient preference was, how often do you want to inject yourself? But now we have injectable treatments, we have oral treatments, and we have infusion treatments. So what would the patient prefer? What would fit into the lifestyle? Some patients will say, I am not good at taking pills. Other patients, I prefer to take injections because I take a lot of pills. Some patients prefer infusions because they can do that and have it done, and don't have to worry about medication until the next infusion. And then it's good for the patient to talk about resources. And resources can cover a whole lot. insurance costs or in terms of time off from work or how it impacts other things. And when we put all of these together, then we come to a common or shared decision about the best medication for patients. So shared decision making is mutual, and everyone should rely on all the benefits that it can present in making the MS journey for patient the best, because MS is a very devastating disease, and patients need all the support that they can get in the MS journey. Moving forward, let's talk about therapy selection. So I talk about what each party brings to the table when they're making the decision about a treatment, but there are three core things that have to be taken into consideration when you're making a choice for disease modifying therapy, and that's DMT, as we call it. We have to take into consideration the disease activity. What do we see on MRI? What is the patient clinical picture? And what is the risk of the patient progressing to disability over time? We as a provider, I have to take that in mind. Then I also have to look at my clinical experience and say, I've seen this picture before, and what are the treatment that I know will be most effective for this patient based on this clinical picture I've seen. And then I take the individual patient preference. I can say this is the best medication for you, but if the patient does not take that medication or it does not fit into the lifestyle, then it may be the worst medication for the patient. The best medication is the medication that the patient will take. So we have to put all of this together, and we see each of these are huge boxes to make this one choice for a patient, which is the disease modifying therapy choice. Moving forward, now that we have talked about the shared decision making process, here are some of the benefits that you can reap from it. For patients, they can learn more about the disease when they talk to their provider and have a conversation with them. They can understand the pros and the cons of therapy. Once again, there are lots of information, but taking it out and taking that information and putting it into context can be done with the help of your provider. And you can discuss and weigh the options for you and what's best for you. You can share your preferences and concerns about medication, what you have read, the treatment options and all of that, and help shed light on what you would like. And then be aware in what is required for the monitoring for potential side effects. And I say potential side effects because there are lots of side effects that may be listed, but that doesn't necessarily mean that they may occur. So potential side effects and how to monitor for them. And by knowing all of this, it can help patients to adhere to therapy and achieve the goals of treatment. All right, moving forward, we talk about shared decision making. Let's talk about the future of MS therapy. And I put this busy slide up here again. Once again, it shows the complexity that researchers are faced with. It talks about the complexity of the medication. It talks about the complexity of the disease and the targets that we need to look at. To the next slide, we're going to look at. So for the next slide, the future of MS therapies. Let's talk about that. So the busy slide that I showed you, there are lots of new targets for treatment. Most of our medications before really focus on inflammation. So in the early stage of the disease, when we can see activity on MRI, we can see the inflammation that is caused by the immune cells and what is the damage that is causing and the clinical relapses that we see. But what we are focusing on now is not only inflammation, but looking at degeneration. What about the changes that we see even when there is an active inflammation? So the one target of our future treatment is trying to manage degeneration and slow degeneration down as best as we can, so that patients who are experiencing degeneration may also benefit from our therapies. Another thing is the central nervous system. Most of our treatment options have been focused on the cells before they enter the central nervous system, and sometimes when they do enter it. But what about the immune cells that live in the central nervous system? We haven't had a good target for them. So the newer treatment targets that we're looking at are those cells that live in the central nervous system and are causing damage to the nerve. So we're going to focus our research on that as well. Another thing that we're also looking at is dosing regimen. So before, the choice was you take medication continuously to control the disease. But now we have a few therapy that you only take intermittently and further apart, so not daily, sometimes monthly, sometimes every 6 months, versus continuous to provide more flexible options for patients over time. And then that will allow patients to have more options. Another thing is, and for people who have had MS for a long time, and even if you're new to it, you may or may not have heard that MS is very individualized. Everyone is different when it comes to MS. So looking at precision medicine. So how can we target the disease in individual patients as opposed to a group of patients? And then the next thing is increased availability of medication. And we'll see that in the following slides. What do I mean by increased availability of medications? So the future of MS therapy continue. So let's talk about conventional drugs, then I'm going to go into biologics, and then I'm going to go into biosimilar. And this falls under the umbrella of availability of drugs. So conventional drugs, so those are your regular pills and medication that you take. Think Advil, Tylenol, for example. So for MS, conventional drugs are chemically made, so they are made synthetically. The structure of the drug is well known. So this is how the drug looks, and we have that. And the process to make the drug is also well known. So if we have drug A, we know what the structure looks like. We know what the manufacturing process is. It can be made. So you have a recipe, and if you follow that recipe, the pound cake can come up exactly as it should come up if you follow the recipe. And so when a conventional drug, when the patent runs out, and this is a new thing I've introduced, when the FDA approve a drug, is approved for a certain length of time, then you can have generics come on the market. Generic is created the same as a drug that has already approved. And why do I say the same? Because the recipe is there. So the structure is known and the manufacturing process is the same. So it's created the same. So the dose must be the same. The safety profile must be the same. The efficacy profile must be the same. Quality and performance must be the same. And it's considered an equal substitute. So for conventional drugs that you have the recipe, you have the process to make it, you can have a generic for it. Moving forward, we have moved past conventional drugs. We now have biologics. What are biologics? Biologic drugs are drugs that are derived from natural sources. What do I mean by natural sources? They're usually from a human-made cell, either protein or other cell lines, and it's all from natural sources. And to manufacture it, it can be very complex. So it's not one particular recipe. It's not here's how you make it and you have this end product. It's very complex in how it's made. And if you change just one little item, you can have a different molecule altogether. But what is unique about biologic is that it specifically targets inflammation, certain pathways. And in the immune pathways, that's important because sometimes where you don't have other treatment that will work, the biologics come in and do a good job about it. Biologics are usually large molecules, so they can be fitted into a pill form normally. So it's usually an injection or an infusion, and usually it's at the cutting edge of treatment today. Okay, so we have defined what biologics are. Now let's talk about biosimilars. All right, so biosimilars have no clinical or meaningful difference from a biologic. It's similar to a biologic, hence it's called a biosimilar. Clinically meaningful, there's no clinical meaningful difference. And you have clinical trials to prove these findings. So a biosimilar also have clinical trials to say, we have proven that there isn't a difference from this biological. Is where once again you see the word similar. It's highly similar to biologics in that the strength and the dose are the same. How it's administered is the same, and the same efficacy and side effects. What's the advantage of biosimilar? It can provide, patients can have more access to treatment. So remember I said biologics are very targeted and it targets inflammation and immune pathway, and where no other treatment has worked, it can provide work. Well, if you have biosimilar, you are making more drugs accessible to patients and to treat that hard to treat disease. Usually these are inflammatory diseases, these are cancers, these are things that, once again, a conventional pill is not going to do the job as good as we want it to be. So that's what biosimilars are. The two criteria for biosimilars is that there has to be no clinical meaningful difference, and it has to be similar to a biologic in terms of the strength, dose, efficacy, and potential side effects that may occur. So let's talk about biologics in MS. What are some of you are on biologics and you don't even know it? But let's talk about what they are. For all those who had injections in the past, and it was only injections, it was because you were on a biologic. The interferons, such as Avonex, Rebif, beta-serons, those are biologics, and it couldn't be fed in a pill, so you had to inject yourself. Then we had the infusion come along, natalizumab, also known as Tysabri, alemtuzumab, also known as Lemtrada, Ocrevus, known as Ocrevus, ofatumumab, Kesimpta, and rituximab, Rituxan. Those are biologics that have been used in MS. I put glatiramer acetate on here. So glatiramer acetate is not technically a biologic, but because it's so complex in the structure, because it's complex in how it's manufactured, it's almost in a sense a biologic. And what do I mean by that? I'll show you later on in the slide. Because it's so complex to manufacture, to get together, it could almost be classified as a biologic. Next. So, oh, I missed one slide in here. I'm sorry about that. But if we could go back, yes, go back one slide. When we talk about the biologics, now we have to talk about biosimilars in MS. So, the interferons all have medications that are biosimilars now. And as I mentioned before, when a drug is approved for treatment by the FDA, it has a certain length of time that it has exclusive rights to the market, but after that runs out, then that opens the door for biosimilars to come on the market. Rituximab already have biosimilars on the market. The next slide is my summary slide. So let's do the summary and then we can open it up for Q&A. MS is a complex disease. I showed a slide of the complexity of it. Shared decision making helps to provide understanding for both the patient and the provider and improve treatment options for patients. As the MS treatment landscapes continue to expand, we have drugs with novel mechanism of action, and with the availability of biologics and biosimilar treatments, we have given patient more access to treatment options. And with that, I will stop and hopefully we can get on to Q&A.
Okay, so let me open up with this first. Since we were just talking about biologics, all right? Questions that have come in and questions that I had for you as well is, what do you have on the variance between pricing between biosimilars, brand and generic?
So I do not have exact numbers. What I have heard and few that I have seen is that, let me take a step back. So pricing is very complicated when it comes to the US healthcare system. So what we see as pricing may be different from what is actually purchased. So I will talk about what most people refer to as wholesale acquisition costs. And that's what patients see on the explanation of benefits and it's showing, so that's what I will speak to. And what I know when it comes to generics, biosimilars versus the branded, there is a variation between a 30% variation between the cost of the brand versus the generic or biosimilar, if that helps.
I'm sure it does. For whoever asked that, I'm sure it will be great. Let me jump to something really simplistic and maybe we'll get a great feed again on here, okay? And that is, why is vitamin D so important to people with multiple sclerosis?
Vitamin D, the sunshine vitamin. Wonderful. Vitamin D is important because not only is it the sunshine vitamin, it's also a vitamin that plays a role in the immune system. So it's not just a vitamin. It actually has an immune system role. And what did I say earlier in the program is that MS is a disease of the immune system affecting the neurological system. So vitamin D provides certain support for the immune system. And because of that, MS patients need to have adequate levels in the system in order to continue to support the immune function.
Great, thank you. I want to let you know I had COVID back in January and I was told to take very high dosages of vitamin D above and beyond where I even took high dosages for vitamin D. So I think that that helped me get through it a little bit quicker.
It could have, yes.
Could have. All right, next question. Person is asking, what is the timeline for Copaxone? So like you and I had conversation before the program began of people not knowing what necessarily interferon A or interferon B is without saying the name, or maybe they don't know it at all. So this question now comes as particularly, when was Copaxone on the market, and what is the difference between Copaxone and glatiramer acetate?
So Copaxone was approved by the FDA in 1996, 1997, 1996. That's when brand name Copaxone was approved. Now, the glatiramer acetate and Clatopa was approved 2000, and I think I have to go back to my slide if I'm not mistaken, but I think 2015, 2016 was when generics, because it's not considered a biologic, even though it's complex, but generics for Copaxone was 2015, 2016. That's when they were introduced on the market. Okay. Is that what the question was?
I believe so. I believe so. Okay. But I think that they also want to know, another person was asking, so where would they be better off, staying with brand or going to the glatiramer acetate generic?
So at this time, with the generic being on the market for at least 5 years, we have time to look at it anecdotally in the real world. So we have had real world experience with these generics on the market. And there hasn't been any signal that the generic is less efficacious than the brand. So at this point, it all depends on what the insurance will cover for that patient. I can say personally, as a provider, if the insurance is requiring a generic of Copaxone, I go ahead and prescribe that. If the insurance will pay for branded, I go ahead and prescribe that. I don't discriminate between the two anymore because it has been on the market enough years to say, okay, either or, you're treating your MS. So it all depends on what is being provided, what is being covered by insurance companies. Sure.
But we're hearing about a lot of generic pricing, though, that is quite similar to brand itself. So okay. Why is ICER making people, why is ICER demanding that the insurance companies only allow for generic versus allowing the brand?
Exactly. I am not sure why ICER is doing that, because when you look at the wholesale acquisition costs, you will question as the introduction of generics should help to control the high prices of drugs, but that's not what we are seeing. And there are instances where patients are taken off brand and put on generic, and now the out-of-pocket cost for the patient is way higher than they were on brand. So our payer system in the United States is very, I will say the word dysfunctional, and I don't have any answers as to why that is the case and how to make it right. So ICER has to. I think the people who are behind ICER, once again, the experience, the real world experience is limited in that they are not in the field. They're just looking at numbers or looking at, certain formulas when they come up with this. But that question is something that is mystifying to both providers, to patients, and anyone who just look at it besides the people making the decisions.
So I have good news about that. And being that Use the News is part of the MS Coalition, and the MS Coalition has been, providing a lot of information to ICER recently. I also have had communication with ICER and about the patient's view on this, and that ICER needs to start listening to the patients. So ICER sent me an email just a few days ago for me to put together my own patient ad board that they have questions for us, okay, to learn about the patient's experience with the disease as well as with the medications. And so I am going to need volunteers for this. So for anybody online tonight that may want to be part of this panel with me and ICER, please send me an email. Okay, now let's go beyond that. But I'm just letting you know that there are things being done by the MS Coalition and about separate persons to try to find a resolve to some of these problems that we're talking about with the generic and brand pricing.
Yeah, okay. And the Academy of Neurology has also addressed this several times in the past 6 months, and there is a movement on that front as well.
That's right. Thank you for that. All right, let's take some questions. Cindy online is asking, could you possibly explain to me the difference between Ocrevus and rituximab, as both are B-cell depleters, but yet used to treat different diseases? And I simply don't understand why rituximab would not be a viable option for treating multiple sclerosis.
All right, so Cindy, you are correct. Both Ocrevus and rituximab are B-cell depleters. Rituximab is not FDA approved for treating MS. Ocrelizumab is FDA approved for treating MS. Several things, and I will try to make it as layman as possible. So the chemical structure of rituximab is a little bit different from the chemical structure of ocrelizumab, and I say a little bit different because the basis of ocrelizumab was based on rituximab data. So rituximab tuximab means that the way it was manufactured is slightly different. Remember, I said biologics comes from living cells, so natural sources. So rituximab was manufactured with cells that is what a mixture of human and other. So it's half human mixture in terms of the cell line, whereas ocrelizumab is fully humanized cells. And that's the best layman's term I can use for a patient. All right, so that's the first difference between the two. So look at it as rituximab, and you're changing certain one little thing on here to make it fully humanized, and now you have ocrelizumab. Prior to ocrelizumab approval, rituximab was used off-label. So off-label meaning it was not approved for FDA, but if we fought really hard, we could use it in MS patients. And even now, we can still use it, but it's so hard to get an off-label approval for rituximab when you have an FDA-approved treatment, such as ocrelizumab. Those are as simple as I can make it. I can talk more about that, but then it will become a little bit more complicated.
Sure. We don't want to hear it. We don't want to hear the clinical answer. Okay.
Yes.
All right. So I want to remind everybody that are online. I mean, most people are online and they're from the East Coast, and it is 8:30. And normally we would be ending this program around now, right? But we started a half hour later for the benefit of Dr. Okai because she's in Central Time. So we will be, on here for at least another 30 minutes. Okay. All right. Great. All right. Next question. Again, the question comes up is, what is the difference between the biosimilar and the generics?
So once again, biosimilars are from biologics. So they're from natural sources. They're from human cells. Generics are the equivalent of the conventional drug where it's made synthetically. Okay, so those are two different. When you say generic, We're talking about conventional drug. You have the recipe, you have the structure, you know how it's manufactured. You put all of that together, you come up with something that is equally substituted for the marketed drug. Biosimilar is for biologic. Remember, these are complex molecules. These are complex molecules. How to make it is also very complex. And if you just switch one little ingredient, so you can substitute egg whites for eggs, okay, that's as simple as I can make it, Stuart. You can substitute egg white for eggs and still have the same product. So a similar is for biologics because it's very complex, complicated. You have to think about purity of how you're producing it. You have to think about are you using the right cell lines in terms of the manufacturing process. Whereas generics is, here's the recipe, you do that, and it's synthetically made, and you have the equally substitutable product. Biosimilar, you have to prove that there's no clinically meaningful difference between that and the biologics, and that is the same, what we call pharmacokinetics. And what do I mean by that? When you administer that biologic, in terms of how long it takes to have an effect, in terms of the side effect, in terms of the efficacy, all of that has to mirror the biologic.
Okay, very good. Thank you for that. Is that like the difference between yeast and flour?
Something like that.
Okay. Going further with that, when you say biosimilar being having an animal connection, is it human or animal? And if it's animal, is it? I mean, you said a living organism. So,
yes,
but are you referring only to it being a human byproduct, or is there something that could be in there of an animal byproduct?
It can be both. It can be animal, it can be human, it can be a combination of both.
Gotcha.
All right. And so, and I don't want to make anyone here afraid. And it's not, and this is not it, because I will take a common example, insulin, which is commonly used to treat diabetes. Insulin is made from animal cells, pigs, okay? So it's not a bad thing when we say animal. There's no cruelty here, I should say that. Right. So when it comes to biologics in MS, it's the same as well. Take, for example, the interferons. So we're talking about Avonex, beta-serum rebif. Those are made from animal cells. Animal cells, hamsters actually is the living cell that interferons are made from. If we're talking about the monoclonal antibody, so rituximab is part animal and part human. Those cells are combined. So we call them chimeric. It's not a new process. It's something that's used in cancer as well, in terms of cancer drug. And as I said, no animals were harmed during the making of this. It's just the cell lines that they're using. Okay, and then whereas ocrelizumab is fully human cells.
Okay, thank you. So, like Rebif, was that considered to be a biologic?
Yes, Rebif is a biologic.
Okay, that's why it has Chinese hamster eggs, right?
Yes, correct.
Gotcha. I was always amused by that when I was taking it.
Yes, yes, exactly.
Okay, so is there a biosimilar then for ocrelizumab, or is that yet to be produced?
That's yet to be produced. To be produced. Ocreva still has exclusive rights right now.
Great. Okay, so do you know of anything that might be being in the works for something like that? Because we already know that all the drugs have an end life. So is there something that's in study now to replace Ocrevus?
I'm sure there is. I don't know specifics.
Okay.
But I'll tell you what the life of a drug when approved by the FDA. So when a drug is approved by FDA, it has this exclusive time between 9 to 12 years. All right. So that's the time they can be exclusive on the market, and they, recoup research costs and all of that. There are lots of reasons why they have that exclusive period. That's the FDA and the pharmaceutical industry agreement. But it's between 9 to 12 years. Now, within that time, of course, there's people who are studying the composition of the drug, studying the manufacturing process, and getting ready for when that exclusive period ends to introduce their drug on the market. I must say that they are studying it, but they also have to prove to the FDA that, one, they are similar in terms of efficacy, in terms of dosing, in terms of regimen. So clinical trials are being done that have to be presented to the FDA for the FDA to approve. So you can't just go in a lab and say, I've studied ocrelizumab, and I know the composition, and I know how it's processed, and I've made a biosimilar towards it, and I'm going to put it on the market. No, that also have to go through a rigorous trial process that the FDA has to review and approve for it to come on the market. Okay, so there are also checks and balances for biosimilars as well, just like there are, well, similar to what there are for the biologics.
Okay, great. Thank you for that. For everybody receiving or wondering what my email address is, because there are several of you asking since I made the announcement earlier, you received email to be on this program. Guess who from? That's right. Just send it to that email that sent you all the emails to be on tonight's program. Okay. All right. Next, we have Maria is asking, please speak of patients' options when an immunosuppressant therapy doesn't work. For example, Mavenclad or Lemtrada.
All right. So I will answer this question generally and not personally. Okay. So I'm not sure when we say doesn't work. When I hear a medication doesn't work, that means there's more MRI activity or there is significant clinical progression or more relapses. All right. It's easy when someone's having relapses on these medication to see, because they come in, have a relapse, get better, have a relapse, get better. And it's easy to see when there are changes on MRIs, even when they are, when they have these medication, there are lesions, new lesions or active lesions. What is difficult to tell is if we're only dealing with clinical changes. All right. So if someone has gait abnormality, walking changes, and they continue to see progression or worsening of their walk while on these medication, what is that a failure of the medication? And I'm giving this background because it's important. One, we do not have a cure for MS, but for like most other medical, we do not have a cure for most of them. The goal of treatment is to slow down disability progression. That doesn't mean there isn't going to be some progression. So if the slope, if you're starting here and you're just going downhill like this, so their slope is very steep, if we can just make that slope a little bit shallow, so you're not going downhill, but it's slow, that is still a success. And it's hard to say this because for patients, function is being impacted. And if I say I made your slope a little bit shallow, but you're still seeing changes in that, then it may not be what they want, to hear. So with that background, if there are more relapses, if there are more MRI changes, then we look at another immunosuppressant in a certain period of time. So we know with Mavenclad that if you do that in the first 2 years, the recommendation is you have to wait at least 2 years or until lymphocyte rebound. And if there's progression, then you consider a different medication. And that's just for safety reason and not really, mostly for safety reason. But once again, with Nemtrada, there are people that will have breakthrough disease after the 2 years of treatment. And the option is they can get an additional year of Lemtrada or consider a different immunosuppressive. So there are still options if you have had these therapies. You just have to look at what was our metric? What are we measuring when we say it didn't work? And then, okay, what are options? And there are options, you go to another immunosuppressive. Because once again, the mechanism of action is different with these medication. And we have to say, if this mechanism of action isn't working, let's try another one.
Great, thank you for that. All right, for the few people that are asking, when will the replay be on? As soon as I can. Okay, just keep checking with our YouTube channel, please, because we are behind. We are back to doing, 10 virtuals a month plus 3, 4, 5 in-person programs per month. Again, yes, we are back out on the road doing these events. So sometimes it's taking a little bit longer to get them back online again, but generally within 10 days. Okay, thank you for that. All right. Cindy just wants me to tell you before I go to any more questions to please thank Dr. Okai for the time she has put into trying to help us understand and for her brilliance in explaining things so laymanly well.
Thank you, Cindy. I thank you. I hope I'm doing a good job of that.
I think you are. Okay. Otherwise, I wouldn't have asked you to be on here, right? Okay. Okay. Next, MRI. What is happening with the advancement of MRI and now with artificial intelligence imaging?
All right, so MRI advancement. Quick question. So there are lots of things we're doing with MRI in the research arena that hasn't quite reached the clinic yet. Okay, and so the issue with MRI is if you have a new sequence or a new type of MRI, you have to make it generalizable. So once again, think about different companies making tomato soup, Campbell's versus Progressive versus whatever brand you have out there. All right, so you have to make tomato soup that everything tastes the same to everybody, regardless of which brand they're in. And that's the same thing with MRI. We have different manufacturers for the MRI, and we have different software. And that's the issue. The software is different for each one. And so if one person designs this software, you can, it has been difficult to then use it in another setting. So I'll give you an example. You have clinical trials for different medication, but this clinical trial is using this type of software, and this other clinical trial is using this type of software to see how much the brain atrophy or how much brain shrinkage there is. Well, you're going to get one answer from this clinical trial in terms of brain shrinkage and another answer for clinical trial in this other clinical trial. So what we have seen is that, oh, we did this clinical trial for this medication, and we initially used this software to test brain shrinkage. Well, we didn't see a big difference, but when we went back and used this other software, we saw a difference. So you see what the dilemma is when we come to MRI, is that the measures that we're using is not generalizable across the board from clinic to clinic, from clinical trial to clinical trial. So now it's difficult to bring that. So what comes to the market, or what comes to the clinic, is something that if you go from Rhode Island to Florida to Texas to California, and we do the same type of scan, the interpretation can be the same. AI, and let me just speak to AI, Stuart. AI is exciting, but AI is also human driven as well. Okay, so if you put quality data in, you're going to get quality data. If you put garbage in, you're going to get garbage out.
I'm so glad that you said all this, because you know that I was at the Consortium of Multiple Sclerosis Centers conference this past week, and in the exhibition area where I was, there were a lot of AI companies out there for MRI. And I went to the different booths and I heard different explanations of their imaging. And I'm like, where does this make any sense? How would I possibly explain this to somebody? So this question about MRI, AI imaging, that was my question. All right.
Okay.
And that was my question, because I clearly did not understand what all these different companies were saying, and how basically each one was saying how theirs is better than the guy in the next aisle,
Mm-hmm.
And
Yes.
so your answer was beautiful. Thank you for that. All right. And speaking of beautiful, Maria wanted me to let you know that your explanation of the immunotherapy before that, you're an excellent conversationalist, and she wanted to thank you.
Thank you.
All right, great. Aileen is asking something that I would, and it's nothing against Aileen, because there's a lot of people out there that especially during COVID came up with the wrong thing, thinking that people with MS, or that the medications are immune suppressed, or that people with MS are immune deficient rather than the opposite. So can you please explain if injections such as Copaxone suppress the immune system, what effect, if any, does the body's ability to fight off COVID? So
All right,
you'll turn that all around, right?
Yes, exactly. So there are two categories of MS medication. We have immune modulators. So they do not suppress the immune system. The goal is to try to shift the immune system from inflammation, from being pro-inflammation, shifted to being anti-inflammation. So those are immune modulators. You're shifting the immune system. And then you have immune suppressants, where yes, the immune system is suppressed. So now that you understand the two, not all MS treatments are immune suppressants. Some of them are immune modulator. Copaxone is definitely not an immune suppressant. In fact, it's an immune modulator. So when you are on Copaxone, your immune system is not being suppressed. All right? So that is the first thing. And there are lots of other MS medication that do not suppress the immune system. But for those that do suppress the immune system, like the B cell depleters, think about your immune system as a compartment. And that compartment have several parts. Okay? So you have a compartment to fight viruses, you have a compartment to fight bacteria, parasites, fungus, all different compartments. With our MS treatment, we are not suppressing the entire immune system. Okay? With our MS treatment, we're suppressing only one part of your immune system. So you still have all these other parts intact. All right, so yes, while the immune system is suppressed, you have other parts intact that can sometimes come and take over. So you do not have to be, unlike a cancer patient where everything is suppressed, MS medications are different. Another thing you should know about MS medication is, yes, I am saying that this is being suppressed, but not the entire thing. Some medication, the suppression is this much, whereas other medication, the suppression is way more. So the degree of suppression also varies from one medication to another. So just being on an immune suppressant, as we call it, doesn't mean that nothing is working and your body cannot fight anymore. Your body can still mount a immune response, as we call it. It can still fight off when needed. Some immune suppressant doesn't even kill cells, it just traps it, and when your body needs it, those cells come out. So it's all variable, and it's not one size fits all. We didn't just kill off your immune system and leave you out there just susceptible to any bacterial viruses that come about. There are different degrees of suppression. Your body can still mount a response to different organisms as they come. I hope that covered the question.
Yeah, I would believe so. So can you list out, please, which are the immune suppressant medications? Just a quick list.
I will give both, just for completeness sake. So for immune modulators, we have glatiramer acetate, which is Copaxone. We have the interferon, which is Avonex, beta-serum Rebif. We have Glatopa. We have teriflunomide, which is Aubagio. We have Tecfidera. We have dimethyl fumarate. Those are considered immune modulation. They are not put in the immune suppressant category. Immune suppressant will be ocrelizumab, alemtuzumab, natalizumab. So that's Lemtrada, Ocrevus, Tysabri, Kesimpta, which is alpha-tumumab. We have Mavenclad. And even within those immune suppressants I'm listing, not all of them just put your immune system in the dump. And I don't have the full list, but that's just off the top of my head. Then we have fingolimod, which is Gilenya. We have Mason. We have Zeposia. We have Ponvory. Those are pills, and the immune suppression even varies between those medications. And those are the ones that don't kill off your cells. They just keep it in your lymph nodes. So that's a different type of immune suppression.
So what about Plegridy and...
Plegridy falls on the interferon, so it's an immune modulator. And Extavia, interferon. And
the new Biogen drug that begins with an A.
Fumarity, which is diroximel fumarate. Yeah, that's falls under immune modulation.
Okay. I was always told that Tysabri is not an immunosuppressant.
It technically is not an immune suppressant. If we want to look immunologically and how it works, but for the purposes of certain immune suppressant, you have, for a drug to be classified as an immune suppressant, you have the susceptibility to opportunistic infection, change in your lymphocyte profile. And those two, Tysabri, fit that category, hence the immune suppressant label. But if you look at the mechanism of action, it doesn't fit that part. But
Right.
Definitely opportunistic infection, it fits it well.
Great.
So.
Okay, great. I have like less than 6 questions left, and I'm asking everybody to hold off on anything else because we are running out of time, and I don't know how she's going to do 6 questions in 6 minutes. So I guess that means I have to talk less. But
lightning round.
Exactly. First, Aileen wanted me to say back to you that she said, "Thank you, doctor. I wish my MS neurologist explained this to me. with the answer that you just gave. I chose to stop taking MS medications, obviously for the wrong reasons. And that referred to her stopping during COVID. So, okay.
Yeah.
Okay. All right. And there was another person that just wanted to say thank you very much for all your answers. All right. Quick answers needed for the following. What treatments do you have for SPMS?
SPMS approved treatments are Mayzent, which is siponimod, ozanimod, Zeposia, ponesimod, which is Ponvory, SPMS. So there's active SPMS. So you have dimethyl fumarate as well. You have ofatumumab, which is Kesimpta. You have Mavenclad, which is cladribine. Most of our newer medications have been approved for active secondary progressive. By the way, in the FDA.
And they're used for relapse remitting as well.
As well. Teriflunomide, also active secondary progressive.
The dimethyl fumarate, what's the common name that people will recognize?
Dimethyl fumarate, Tecfidera is the brand name.
Exactly. Okay, I knew that, but I wanted them to know what you were talking about. All right. All right. Next, Linda writes, what is the PPMS diagnosis criteria and how reliable is it? PPMS, for those that don't know, is primary progressive MS. And in other words, what is the rate of assurance that a PPMS diagnosis is not relapse remitting?
Well, primary progressive MS is you have an initial episode and you continue to progress in the absence of relapses over time. So you do not have relapses in primary progressive MS. That's the key. Relapse in MS, you have relapses, you get better, even though sometimes you may accumulate disability with each relapses. But primary progressive, there are no relapses there. If there are relapses, then you're active either relapsing or active secondary progressive, depending on the time frame.
Great, thank you. Patrick is asking, what are your thoughts on the S1P class?
S1P are a great group of medication, and all our medication have a role in MS. You know, S1P has been approved both for relapsing and active secondary progressive MS. That provides stability for patients that meet all the goals, which is reducing MRI activity, reducing relapses, reducing disability progression. So very good. Patients can be stable on it for a long time. A good class of medication.
Good, thank you. And Veronica is asking or saying that, and I guess this is very general to say, but I'll read it the way she wrote it. And that is, I'm on a biologic Ocrevus. How do you know what the docs are really, the meds are really working for you? How was it determined that this is the better medication for me? And what was my doctor looking at?
Well, I can't speak for your doctor, but once again, if we reduce how many relapses you have, if we reduce MRI activity, you're not developing lesions over time. And if we slow any clinical changes over time, that's how we measure how our MS treatments are working. So if I see a patient and the MRI is active and there are certain features I see that tells me, oh, there are lesions on here, active lesions, relapses are common, or getting a whole lot of steroids, ocrelizumab is a choice for that patient.
Okay, great. And now one final question that Stuart wrote, because Stuart knows that the MS community needs to know about this, okay? And that is, when will there be a personalized treatment option for each patient using biomarkers?
All right. So first we have to get the right biomarker, Stuart. We have several biomarkers that are in play, but we have to make sure, once again, that is generalizable. But in terms of precision medicine, there's research going on. Excited about the research. Still in the phase 1, phase 2. I do a whole lot of clinical research, and one came across my desk, it's still phase 2. So in, 20 people less, trying to make this a personalized option for each patient, because MS is such an individual disease. So it's not far, but in a way, it's still a ways off, and we are looking at it actively.
Perfect. There are several people writing that this session has been great. So again, my thanks to everybody that was online. Of course, great thanks to Dr. Okai for being here and educating all of us. And we hope that you take this information forward. All right. I do want to say goodnight to everybody, and, you know, drive carefully, be safe. Storm season out there. Thank you. Bye-bye.
Bye, everyone. Thank you.